Okay, so we will get going in our breakout. As I said, this is the breakout for solutions on fighting the infodemic of misinformation. I have with me here Rosamund Lewis from the WHO and Jonathan Ahadi Luhango from Translators Without Borders. There he is, down in the Congo. So both are here today to give an important perspective on the big topic around the misinformation and the rumors and the myths, what's truth, what's not, how to distinguish between all of the information being communicated right now, and also how to disseminate the information through effective campaigns on platforms, and how to reach those with limited access to technology and literacy, disabilities, and other needs. Before I hand it over to Rosamund, who's going to kick us off, just a couple housekeeping things. You will be all on mute during this breakout, apart from our speakers and myself, but feel free to chat in your questions, comments throughout the whole 40 minutes that we have together. You can do that just by clicking the chat button below in your Zoom tab bar. And then we will take your questions for a discussion later on. I'm going to hand over to Rosamund in just a sec. Before we do, we wanted to post a quick poll around COVID and some of the biggest myths that you've personally seen spread through COVID-19. You as the audience are dialing in there. So you can see the question. Just go ahead and submit your response. There's 4 choices there. We'll wait for those to come through. A few more seconds. Biggest myths you've seen spread during COVID-19. COVID-19 treatment, when and how to use face masks, transmission of COVID-19, or the origins of COVID-19. Okay, and we will end the poll there. And if we just share those results, looks like origins of COVID-19 seem to be some of the biggest myths or misconceptions people have. So with that, I will hand over to you, Rosamund, to speak to this and share some of your experiences on what you're noticing right now.
Sure. Thank you very much. I think I still have the poll on the screen. I guess I'll close that. Are you seeing me?
We can see you. You look great. No polls.
Okay, all gone. All right. Well, our discussion here today is about infodemic management and what is that. So our Director General, Dr. Tedros, has said we're not just fighting an epidemic, we're fighting an infodemic. And fake news spreads faster and more easily than even the virus, but is just as dangerous. And even our United Nations Secretary General has said we are also seeing another epidemic, a dangerous epidemic of misinformation. I think we have seen many examples of this from people drinking alcohol products and the thought that alcohol will actually destroy the virus, and various things like this have happened all around the world. So what is an infodemic and how does it come about? An infodemic is really too much information. It can be some good information, but also false and misleading information in the digital and physical space during an acute public health event. It leads to confusion, risk-taking, harmful behaviors, and ultimately mistrust in governments and the public health response. And that's very much what we have been seeing during some of this time. And so what is it that we want to do to address this? We want to ensure that people everywhere have access to the right information at the right time, in the right way, to enable them to take the right actions to protect themselves, but also to protect others, including, of course, those they love and those with whom they are most frequently in contact with including their community and their colleagues. So how do we do this? How do we deal with this wave of information that comes from all sources? And so the first is that we try to identify the evidence. We try to listen. We have monitoring systems. We have new language, new terms, as was mentioned in the plenary, infovalence as opposed to surveillance, social media listening, which is more active, actually paying attention to social media, whether it be through different spaces, through Facebook, through Twitter, through WhatsApp is much harder to access. That's one of the issues. But we can listen and watch what's happening. And we listen to those narratives. We want to know, what is the story? Where did it start? How does it move from one place to another? How does it evolve? And we're seeing a number of different things. For example, we're seeing things that start as independent, disparate little stories begin to coalesce into a conspiracy theory. So if I could just use an example of that, you've probably heard that a number of people are concerned that 5G may be in fact what's causing this illness, and that the 5G may actually be bringing the virus even. So that's already two separate elements. And then we hear that large foundations or influential people are behind the production of a future vaccine, and how they're going to deliver the vaccine is they're going to deliver it by a chip under the skin, and then the 5G will inform the chip, and then people will have their movements monitored and so on through this. So you can see how elaborate it can become. It can go from small little bits of misinformation and misunderstanding or myths, whether they be, as I say, misinformation, which is basically misunderstanding or sharing information that is not correct, or disinformation, which is very deliberate to try and put out information that is demonstrably not true, but that the people who are putting it out know it's not true, but it's a deliberate thing. So we listen to these narratives and these questions, and in epidemiology, we have an approach that says we want to identify an outbreak by person, place, and time. Who's getting it? Where is it? Where did it start? Where is it moving to? And how does it evolve over time? But with information science, we can do the same. We can say who, what, when, where, and of course, eventually why. So who's sharing it? What are they saying? Where is it moving from? Where is it going to? How's it evolving over time? And one thing that's different between information science or the infodemic and an epidemic is that this, as was clearly said by our DG already, that this information moves even faster than the virus itself. So we're always trying to get ahead of the curve in terms of finding myths and finding ways to correct that information. And then in order to formulate the correct message. So it's not just about debunking myths, because sometimes when you share an incorrect message, you actually give it more oxygen, you actually spread it. So you could say, this information is not correct and share it, but then you've also already shared the actual information itself. So sometimes we need to think of ways to put out the correct information without necessarily even sharing the incorrect information. So it's a very fine balance as to how to do that. But everybody can do it, and it's important that we engage all our partners in doing this, and that we adapt, of course, to the needs, the language, the local context, and so many other things. So the purpose is to engage people to amplify the correct messages and to influence health-seeking behavior so that people know where to look for the right type of care at the right time, whether it be by following their traditional routes of essential services, as we've heard about already today, by picking up a phone for a hotline, calling their own healthcare provider. These are all important ways to do this. So we use this framework of identifying myths or misinformation, or even identifying new science that's coming out. So for example, science is also an issue because it's evolving. As this is a new virus, it's a new outbreak, it's a new pandemic. We're all learning as we go. And so sometimes the science changes a little bit or evolves a little bit, and then that can lead to mistrust, loss of trust, and that's the challenge. And then even the infodemic of scientific publications, of course, is really important because there's so many articles coming out. It was already mentioned in a previous working group, so much information coming out all the time that even public health professionals can't easily keep up. And so managing that information flow, identifying what is the key message for a general public audience, and distilling that message, and then sharing it in different means and ways. And so this is what we'd like to share with you today. There are other examples of parallels between epidemiology and infodemiology. So you've all heard about the very high infection rates that we have in closed settings, cruise ships, seniors' homes, all these things. But information, the information world can have similar things. You have closed Facebook pages, you have closed groups, you have the deep web, and these are also echo chambers. And in these echo chambers, people hear what they want to hear. Even in a Twitter feed, which is open, you might only hear what the people you followed and the hashtags you've used, and so you end up hearing more of the same, and that becomes a challenge because information infection rates in those settings are also very high. So that's what I wanted to share with you. We do have ways of staying away, keeping our distance from fake news, but I'd like to hear from Jonathan and from the rest of the participants here today. Thanks very much.
Thanks, Rosamund. And just a note to everyone, Rosamund's video has come back to life. It has been a bit frozen, but we can hear you okay. So sometimes if it freezes, it's just a case of refreshing. Thanks, Rosamund. I'm going to hand over to Jonathan to speak to his experience down on the ground in the Congo in terms of what he's seeing with the role information's playing, how it's moving, and how it's affecting people with different language barriers. So Jonathan, if you want to switch on your video and unmute. Okay, and just unmute and you're good to go. Sorry, Jonathan, just click the unmute button, bottom left-hand corner. There we go.
Thank you so much. So I was saying, like, in Congo, in this context of pandemic, especially of Ebola and COVID-19, so we've been seeing people they don't get information that they need, because most of the time when it comes to communicate, to talk to local population, so humanitarian most of the time come from abroad, as you can see in DR Congo. So the fact that in DR Congo we have more than 100 languages, that is a huge problem when it comes to communication. And I've seen people, for example, coming for response, coming from other areas from DR Congo, because I'm in Goma in the eastern DR Congo. Some of them come from Kinshasa, the capital city, but they come with the idea that the fact that DR Congo is in a French-speaking country, everyone in the eastern can speak French. But that is not the point. So they come with that issue, and it's become a big challenge for the local population. And some of them, they don't seek treatment because they don't understand. So they feel confused. They don't know how to deal with that. They don't get information in the proper language. So it's a huge problem. That's how we always talk to people all the time. When I do trainings, I always talk to our partners that as humanitarian, we should find out, most of all, when you go to a place, the first thing to do is to make a list of languages, all the local languages that are spoken, and then you'll be able to know your audience. You ask yourself, who is my audience, and how am I going to intervene or to give, to take action? That's how it is. That is the context of DR Congo when it comes to response, Ebola response, and COVID-19. So the big problem is about communication, because those local languages, they are not taken into account. Thank you.
Thank you, Jonathan. Now we'd like to sort of switch gears and invite all of you participants to actually move into some smaller breakout groups to give you a chance to have dialogue around what you just heard from Rosamund and Jonathan. So in a moment, Zoom is going to spin you out into about into multiple rooms with about 5 or 6 people. Housekeeping, there will be no facilitator there. So when you arrive, you'll all be on mute and probably cameras off. So go ahead, switch your camera on, unmute when you get to the breakout and introduce yourselves, and have a discussion around what you find most thought-provoking about this topic. And then once we return to the main room in about 10 minutes, you can again chat in questions, comments. Let's keep the dialogue going, and we'll have Rosamund and Jonathan join us to continue the chat. But for now, what was most thought-provoking for you during these presentations? You'll be spun out into your breakouts, unmute, turn your cameras on, have a quick dialogue, and we'll see you back soon. We'll just rectify those questions, but I think in the meantime, Rosamund, if you'd like to speak to your thoughts on what the media's role is in portraying the narrative and conveying information to the public.
Sure. The media has a really critical role, both in sharing good information and when I say good information, so the latest science, how it's evolving, so that people understand the science. There is a responsibility to report. And as I mentioned earlier, part of the challenge is that we have a new mechanism which really hasn't been used much before, which is that scientific papers that are in preprint format are being shared through online websites called medRxiv and others. But those same preprints have not yet been reviewed by peers. They haven't been through the peer review process. They haven't been vetted by the editors of the journal. And so it's a mixed bag of preliminary reports, which then sometimes even get put out on Twitter. And so even if it's not great science or it hasn't been vetted and inconsistencies haven't been picked up yet by peer review, that information gets pushed out into the public domain and can lead to obviously one wave of information, surprise, questions, and then it kind of quiets down for a little while. And then it comes back when the paper's finally published. And again, if they've corrected things and changed them, again, for the public, it can be confusing. So the media do have a role. They have a role to basically explain the scientific process and explain the science as it evolves, as it comes out, and to try not to put too much emphasis on the myths and the misinformation that are being shared.
Annika, you're on mute.
Thank you. This Zoom world we live in. Thanks, Rosamund. Can you speak to, and Jonathan, can you speak to perhaps the role that with all this new information coming out quite quickly and its need to be reviewed, amongst all the noise, there has been some studies from multiple doctors, numerous doctors that have come out with studies on things like high dose vitamin C, the use of that intravenously, and having success rates. How do we reconcile messages from doctors on the front lines and what they're seeing with perhaps what is fake news and just social media spin?
Do you want me to take that one first? So again, it's about the scientific process, right? So there are advocates for specific interventions in every field, including within the medical field and within the field of scientists, people who are very passionate about their topic, and rightly so. And so again, it's distinguishing between, for example, messages that are, what's good for me to basically remain healthy. We've heard about, we can't do much about our age, sorry about that, but we've heard about underlying conditions and how important it is that those actually contribute to a higher risk. And we know that's a fact. And so people want to do their best to improve. Some people want to do their best to improve their underlying health. And that's a good message. The healthier we are, the fitter we are, perhaps the better we can withstand onslaughts such as a viral infection. That's not the same. And for that, we can exercise, we can eat well, we can maintain balanced nutrition, we can take vitamins, we can do all the things that we would normally do to maintain optimal health. That's not the same as an intervention which is given to people who are sick in the hope that it will either reduce their illness or save their life. So that's a very clear distinction that needs to be made for the general public. And some of those things that we consider of our everyday life might turn out to be beneficial in a therapeutic way. But we can't jump to that conclusion until the science has been settled, if I could say that. It's hardly ever settled, but through clinical trials, through randomized clinical trials, through high quality studies with methods that reduce bias and reduce errors and things like that. So then when we can test those things that have promise, and there are many things being tested right now that have promise, but the promise is based on a theory. It needs to be demonstrated through scientific method. And so that's why we need to distinguish between people who are passionate about a particular area, between maintaining optimal health in general for saving ourselves from infections, and the scientific method of testing therapies and vaccines, which is a different thing.
Great. And just a reminder for all you folks listening in and dialing in, use the chat box below to send through your questions. I can't unmute you, but you can send through your questions, so we'll get those heard. There was another question that came up around vaccines. So with the push to fast track this and move towards a vaccine for everyone, what are your thoughts on how safe this can be for people if we're rushing through trials and safety studies? What's the message for people in how to reassure them that it will in fact be safe? Because there's information we're hearing that it won't be safe, and as you mentioned before, a chip will be implanted, hooked up to 5G. So how do we ensure people that this is a safe route to go?
I will pass the floor to Jonathan, but on that one, remember, this is Chatham House rules and we're not to repeat those conspiracy theories that we hear about. But the usual process is that, you have preclinical trials in the laboratory, in vitro, then you have animal studies, unfortunately, but that's necessary to develop theories about how something works. Then we go to preclinical trials, which are first with a very small number of healthy individuals to assess safety, and so on. Then then phase 2 trials, phase 3 trials with a much larger group of people, and obviously phase 3 trials are easy to do in places where the disease, the infection that we're concerned about is actually occurring. And in a moving pandemic like this, it's sometimes you miss the boat, and you're not looking for sick people, but in order to test those things, you need to. It's better if you have obviously disease that you can prevent with the intervention, the vaccine that you're looking for. So what the scientists are trying to do now, and there's over 100 vaccine candidates right now, and already 10 in clinical trials. So this is actually a really good thing. But instead of doing everything sequentially, one bit, then the next bit, then the next bit, then the next bit, we're trying to overlap many of these things. And not all of it is laboratory work. For example, there's the regulatory issues, approval by licensing authorities, import, and of course the whole access and logistics. So the idea is to take each one of these pieces, and rather than having them sequential, if you're developing a vaccine that might be ready 10 years from now, actually what we're trying to do is figure out where we can shorten the process, not to shorten the scientific process of assessing safety and efficacy, no, but of overlapping. For example, if you're still doing some animal studies, you might be able to already start some, on mode of action or something, you might be able to start some the very early clinical trials on safety with small doses. You may be able to overlap some of those stages. So that's what they mean when they say a shortened process. They don't actually mean that we're skipping steps. It just means that instead of being sequential, we're kind of try to do some of those steps at the same time to shorten the end-to-end process. But all the steps are still taken. But I'd like to hear from Jonathan actually about perceptions of vaccine in the field in a very different context. How are people already talking about vaccines in the DRC? The DRC has been very instrumental in studying the Ebola vaccine, for example, exactly in this context, in the middle of an outbreak. How has that influenced people's perspectives?
Well, according to DRC context, so when we talk about vaccine, it's a little bit confusing because most of the time, you know, they always say it's an experimental vaccine. So for people, they think that they wanna try to test the vaccine, and some of them they fear to go and get the vaccine because of that experimental vaccine. So they think that no, why don't they start by their country? They come here with the vaccine, the Ebola vaccine. They should have started in their country before they come here so that they come with the proper vaccine. So that is the conception that the local population have about the vaccine. So it's a big problem for us, humanitarian, because most of the time when we talk to people about vaccine, and even the word vaccine is not clear. If we look the same word in our language, our local languages, we cannot find it. So we have to explain what vaccine is. And as you know, every humanitarian is not a doctor. So trying to explain what is a vaccine, you know, it's become a huge problem regarding communication. So that's how the problem we have. And most of the time, you know, it's not clear when we try to convince people and say, no, you can come and get the vaccine. So they will be like, why? I'm not sick. Why should I go and get the vaccine? So, you know, they don't understand that vaccine is not, it's to protect the person against the disease. So for them, they think that once you get the vaccine and then you even if you were sick, even if you're sick, so you won't, you cannot develop the disease. So when I try to see what is happening, so the vaccine is there, but people, according to Ebola, for example, so the vaccine was there, but people, when it comes to explain to them, to come and get it, so it was a very, very, very big problem, because for them, they was like, no, this vaccine, if they send the vaccine to Congo, they wanna kill us, all of us. So it was such rumors about the vaccine, but I think all that was because as a humanitarian, most of the time we don't communicate with the local population with the right language. So we try to convince them with technical terms. We instead of speaking to them with simple words from their proper their language. So that was the huge problem. Yeah.
Thanks, Jonathan. I want to piggyback off that and speak to the issue of technology and reaching people with limited access, people with lower literacy levels, people with disabilities. What is your view on how to actually share right information with those people and reach them?
Well, as you know, there's a lack of language data. Okay, there's a lack of language data, and as you can see in DR Congo, like I said, we have more than 200 languages. So most of the time, there are such assumption that every or most people are literate, okay? Or most people can understand official languages. So those assumptions are not true, because when you go to some places, some rural places, you can find people who don't even speak. They cannot even understand French, but French is one of official language in DRC, you see? So that's the big problem. So regarding that issue, that's why when we look at gender, women don't have access to education. And they have a limit of technology. So most of the time, information can be shared throughout social media and wherever. So the fact that women, for example, don't have access to education, and the information that is given in French, for example. So you see, that's a big problem. So they, most of the time when it comes to women, they don't know how to go and where to get the treatment when it comes to disease. So it's become a huge problem. That's how that gender perspectives and all that element. But the point is, what we have to know, I think in the context where we look at children, I think in some context, children, we must take the communication with children, we must tailor the communication with children, because most of the time, it might be seen like children have a higher literacy rate than their parents. So I think that children, in some point, can give information to caregivers. Yeah, so that's why we always recommend that we ensure that we tailor communication to children so that children can understand and share content. That's how it is, because I've seen in Congo and DRC in particular, even in many countries in Africa, where you can find children with a higher literacy rate than their parents. Yeah, and then that's how it is.
I think that's a really interesting way of turning the tables. We are used to thinking that it's the parents that educate the children, and maybe in these contexts, we can turn the tables. And another way of turning the tables, I think you've alluded to, is the use of pictograms. We have, you know, through the Mythbusters, and I've seen excellent examples from Nigeria and DRC of very simple visual images, how to protect yourself, whether it's the simple ones of you know, coughing in your elbow or keeping a physical distance, but trying to circulate good information through visual images is also really powerful, and it's a powerful way that can cut across some of those language barriers that you're talking about.
Yeah, thank you. There's on this note, the sharing of information and using children as a way to do that. There's also some questions coming through on whether you both can share best practices for not only how to share information, but also how to promote community partnerships and collaboration with access to valid data and fact-based information. So schools, education leaders, public health experts. And so your thoughts on that, other channels and community partnerships, how to build those.
Yesterday we had our first global WHO conference on infodemiology, which is not a new word, but we're kind of using it in a new way. And actually the day before yesterday, there was a public conference that we also had thousands of people online, and it was a great privilege to participate in that. And our keynote speaker at the top of the whole event was Dr. David Nabarro, who is one of our Director General Special Envoys for this pandemic. And what he brought to the conversation was really powerful. I felt it was basically, he was saying that it doesn't necessarily help to just tell someone they're wrong. If they are consuming false information, there may be a reason, and it may be a reason that's in their environment or the context, or it may be specific to them. For example, if someone has just lost a family member or a loved one, they need an explanation, and it's easy to go grab a conspiracy theory that makes perfect sense from beginning to end, and use that to fill the void. And also, if someone's coming from a place of they don't want to wear a mask because they think they don't look good, or because they want to be brave. Well, maybe if you're appealing to, if you have empathy and you're appealing to their value system, then saying rather, well, actually it's really a brave thing to wear a mask and show that you're respecting others or helping others in the community. So rather than speaking to the actual topic itself and the science of it, which we do need to explain clearly, what is a vaccine does need to be explained. What is immunity needs to be explained. But the thought process or the feelings that are behind how people receive information is at least as important, if not more important. And so by appealing to, by having empathy, by trying to understand, by appealing to the way they process information, we may actually have more of a breakthrough than just saying, oh, here's the science and this is the actual truth, so you better believe this. That doesn't always work. And so one of the ways we do that, speaking to your question about partnerships, is in WHO, we've created, with this pandemic, the thought was on the drawing board before, but in fact it got launched at the beginning in January, is the EpiWin, WHO Health Information Network, a series of webinars, which we have 2 or 3 every week and have done since January, but specifically working with individual stakeholder groups. So for example, right from the beginning, we worked with employers and employees, federations, organizations, big business. We also worked with travel and tourism people. Even before flights were stopped, we worked with a stakeholder group of travel and tourism people who were very concerned about losing, obviously, their clientele and losing business, which has happened. But now they're coming back online. And so we are re-engaging with them specifically to understand their motivation, their needs, the language that they use to discuss issues. And so we do this with faith-based organizations. We have a specific channel, dialogue, with leaders of faith-based organizations. And these are kind of examples where we're doing it in a virtual world, especially now, but it can and be replicated at all different levels. In regions, they're doing the same, countries can do the same, and specific stakeholder groups can also have communities of practice amongst themselves, where they can better understand and better translate for their partners and groups and stakeholders and clients, the issues that are of utmost importance to them, and to reduce risk. It's all about reducing risk, right? So there's no zero risk, unfortunately, and we're going to be with this for a while. So we need to look at it from a risk assessment perspective, and giving people the tools and the methods to understand how to assess their own risk, how to mitigate that risk, and how to protect others. And then people feel empowered. They feel, this is not just about me hiding in my home. This is about what I can do to help my community. And there's many ways you can do it, even if you don't step outside. But if you do step outside, you can do many things. And so some of the messages are very simple. Help your neighbors, drop off groceries, whatever, people who can't get out. But some of them are much more than that, about creating community and empowering communities. And those communities can be physical, as in the DRC or anywhere where we live. And they can also be virtual communities, communities of interest and communities of practice.
Yeah, it looks like there's a lot of support coming through on the chat for listening and empathy being one of the key markers for building understanding on those topics. We have time for a couple more questions till the top of the hour when we return back to plenary. So if there is anything else you wanted to discuss or comments to share, please chat those in. We're monitoring that. There was some actually on the partnerships question, there was one in the breakouts on using artists and musicians as a way to actually proliferate messages, and that getting musicians and artists more involved in sending messages is a powerful way to do that. So I wanted to share that from the breakouts. Yep, great insights on the levels of communities and practice. Thank you. Lots of translation services happening. Just want to quickly speak to some of the areas, so around the mask and the educating the public on wearing the mask. What should people do when information comes out? So recently the WHO published that asymptomatic people are not carrying the disease. You're not passing it on, you're not showing symptoms, and therefore you're not likely to be a carrier. And then that was quickly debunked. So how do you help people understand the correct messaging? If we're sending the messaging, what is the true message if it's conflicting all the time?
Yeah, well, actually, it's not so much that that information is wrong always, but that it does evolve, and that different parties have different roles. And one of the ways that WHO helps lead on the response is to be very rigorous about what does the science show us. But the risk communication side of the response is to be honest about what we don't know, what we know and what we don't know. And this is really, really important, that as we communicate with the wider world in whatever role we have, it's really important to say, well, right now, this is what we know. We think we know, it could change, and this is what we don't know. And one of those things has been the area of how many people can be positive with, or can be infected with this virus, have a positive test while not having any symptoms at all, and distinguishing that from being very early in the illness, or late in the incubation period, early in the illness, where we may just feel, oh, a little slightly unwell, but fine, I'll just take a tablet and I'll be better. And still go out. Actually, you're already symptomatic. So one of the first things we did very early on was try to communicate that the mildest symptoms should be enough to keep you home. It's not just about fever and cough. It's about anything that suggests that you might be unwell, or that I might be unwell. And then after that, it was, well, understanding and recognizing, yes, this is not MERS, it's not SARS, and it's not influenza. And something new that we learned about this particular virus is that during the course of infection, the viral, what we call the viral load, is highest right at the time of the appearance of symptoms. So the 2, even 3 days before. We keep learning a little bit more, but certainly right at the time of symptoms is when the viral load is highest and when people have virus in their throats. This is different from SARS. In SARS, people were most infectious when they were already extremely ill. So even scientists come into something new like this with their own frame of reference. So if you're used to working with SARS and you know that people are very infectious when they're most sick, and now you're faced with something new, and we're learning something new, which is that, well, in this virus, even though it's similar, it actually causes people to be most infectious as symptoms appear. 2 days before symptoms appear and through the first 1 or 2 days after symptoms appear is when people are most infectious. So trying to explain that evolution of our understanding of science is also a big challenge we face, which is why it's so important to not to be reversing, is to say, here's what we know and here's what we don't know, and here's what we think we're learning, and we'll keep you posted. That is a really, really important message.
Okay, thank you. Team, we have to end there. Thank you to Rosamund and Jonathan. We're going to continue the conversation back in plenary. Please use this web link to return back to the live stream. We'll chat in the link as well. Thank you again for your time. Thanks for participating. You can now leave this Zoom call. Thanks.